Okay, hello and welcome back to the deep dive. We've all been there, haven't we? Looking at a stack of revision notes, maybe for something like the MSRA, thinking, okay, how do I make sense of all this? What's really the important stuff?
It can definitely feel overwhelming, like trying to find the key points in a huge amount of information.
Totally. And that's what we're doing today. You sent us your revision notes on amenorrhea, a topic that pops up a lot, especially in medical exams like the MSRA, the multi-specialty recruitment assessment.
Ah, yes, amenorrhea, a really fundamental condition to grasp.
So our plan, our deep dive, is to go through your notes together. We'll pull out the highest yield bits, connect the dots, and hopefully structure it so it really sticks in your head, making these notes work for you.
Exactly. We'll cover the definitions, the causes, there's quite a few, how you'd approach someone presenting with it, the investigations, management, all based purely on the notes you've provided.
All right, let's jump right in. So starting right at the beginning, just like in your notes, what actually is amenorrhea?
Okay, so simply put, it's when a woman of reproductive age isn't having menstrual periods. But the crucial thing your notes highlight immediately is the split, primary versus secondary amenorrhea.
Okay, and what's the difference there?
Well, the definitions are key. You want to remember these numbers. Primary amenorrhea means menstruation has never happened. The notes specify no period by age 15 if secondary sexual characteristics like breast development are present,
Okay,
or by age 13 if those characteristics are absent. Secondary amenorrhea is different periods started but then stopped. The notes say cessation for 3 to 6 months if cycles were regular before, or 6 to 12 months if they were irregular.
got it. So those ages and durations are the first thing to pin down.
Definitely. And right up front, your notes also mention excluding physiological causes. That means situations where amenorrhea is normal, think pregnancy, breastfeeding, or certain contraceptives like, the pill, implants, injections. Rule those out first.
Right, makes sense. So step one, primary or secondary, based on age duration. And is it just physiological? Okay, now the big one, the why. The causes, or etiology. Your notes list them separately for primary and secondary, which seems helpful.
It is because the underlying reasons often fall into different categories. For primary amenorrhea, we're often looking at things that are, well, genetic, congenital meaning present from birth, or structural.
Okay, like what specifically?
Your notes give examples like Gonadaldysgenesis, where the ovaries didn't form properly. Turner syndrome is the classic example they provide. Then there's testicular feminization, congenital malformations of the uterus or vagina, functional hypothalamic amenorrhea, although that can cause secondary too, congenital adrenal hyperplasia, CAH, and even something like an imperforate hymen, a physical blockage.
So if periods never started, think developmental or structural issues first.
That's a good way to think about it, yes. And the notes point out that checking for secondary sexual characteristics helps narrow it down further, tells you if the problem likely started before or after puberty was meant to trigger those hormonal changes. Now, for secondary amenorrhea, the list of potential causes is, well, much longer.
Yeah, I saw that in the notes. Where do we start with that?
Pregnancy. It's listed first again because, while physiological, it's the most common reason periods stop suddenly. You always consider it. Then you've got a whole range of hormonal and systemic things. PCOS, polycystic ovary syndrome, is a big one. Hypothalamic dysfunction, often linked to stress, significant weight loss, or intense exercise. Hyperprolactinemia, too much prolactin hormone.
So hormonal imbalances are key players.
Absolutely. And lifestyle factors, too. The notes explicitly mention excessive exercise, extreme weight loss, and high levels of stress. Then there are endocrine conditions like thyroid dysfunction, either over or underactive, premature ovarian failure, or POF, which is basically early menopause before age 40, and rarer things like Sheehan syndrome, which affects the pituitary after childbirth complications, and Asherman syndrome scarring inside the uterus.
Wow, okay, that really covers a lot of ground. It shows how many different systems can impact menstruation, doesn't it? Brain signals, pituitary, ovaries, thyroid, adrenals, even the uterus lining itself.
It really does. The interconnectedness is striking. It can be helpful, like you said, to group these secondary causes mentally. Hormonal, PCOS, thyroid, prolactin, lifestyle, stress, weight, exercise, anatomical, Asherman, specific syndromes, Sheehan's, premature ovarian failure. It helps organize that long list from the notes.
That's a really practical way to approach it. Speaking of who gets affected, your notes also list risk factors. So who's more likely to experience amenorrhea, according to this material?
The notes mention a few things. A family history of similar issues is one. Weight is another, specifically obesity or very low body weight. excessive exercise, or high physical stress levels. And mental health conditions, particularly eating disorders, are also listed as risk factors.
Right, so it connects lifestyle, genetics, and mental health back to reproductive function. It's not always just a simple biological switch.
Exactly. It broadens the perspective for assessment. The notes then briefly touch on the pathophysiology, the how.
What's the core mechanism described there?
It boils down to two main possibilities, according to the notes. Either a disruption in the normal hormone signaling pathway, the communication between the brain's hypothalamus, the pituitary gland, and the ovaries, that whole HPO axis.
Okay, the signals.
Or structural abnormalities within the reproductive organs themselves that physically prevent bleeding. So fundamentally, it's either a problem with the messages being sent or a problem with the physical parts that should respond.
Signals or machinery. Simple enough concept. Okay, now for the detective work differential diagnosis, really key for exams, right? Your notes give a general list, then specifics for primary and secondary.
They do. The general list hits the most common or critical things to consider. Pregnancy, always. Primary ovarian insufficiency, POF. Hypothalamic amenorrhea, PCOS. Thyroid dysfunction, hyperprolactinemia, Asherman syndrome, and various anatomic abnormalities.
Those are the big players to keep in mind. What about the specific lists for primary and secondary?
For primary, the notes specifically add constitutional delay in puberty, basically just developing later than average. Also, genitourinary malformations, testicular feminization, hyperprolactinemia again, and interestingly, pregnancy less common in primary, but technically possible depending on the scenario.
And for secondary, that list felt quite long when we looked at the causes earlier.
It is comprehensive in the notes. The secondary differential list includes pregnancy, number 1, lactation, menopause if the woman is over 40, contraception effects like the depot, implant, or even after stopping the pill, sometimes post-pill amenorrhea, structural issues like cervical stenosis or Asherman's, intrauterine adhesions, hypothalamic dysfunction, very common, weight loss anorexia, pituitary problems, hyperprolactinemia, thyroid disease, and iatrogenic causes meaning related to medical treatment.
That's a hefty list. How do you approach narrowing that down?
Well, the notes give a really useful hint here. They specifically mention thinking about androgen excess in secondary amenorrhea. This raises a key question from the notes. If your patient also has signs like hirsutism, excess hair, acne, or perhaps some balding,
Signs of high androgens.
exactly, then the notes steer you towards specific diagnoses on that list, like PCOS, Cushing's syndrome, late-onset CAH, or even rarely, an adrenal or ovarian carcinoma. So using those associated symptoms is crucial for navigating the differential list.
That makes sense. It helps filter that long list based on the clinical picture. So using the other symptoms mentioned in the notes is key. Maybe mentally grouping the common secondary causes could help too.
Absolutely. Creating memory aids or structures from the notes is what makes revision stick. Maybe think pregnancy first, then the hormonal cluster, PCOS, thyroid, prolactin, hypothalamic, POF, then anatomical, Asherman's, and finally lifestyle other causes. It's about making the information manageable based on the source material.
Definitely. Okay, quick stats check, epidemiology. How common is this condition based on your notes?
The notes give UK figures. Primary amenorrhea is pretty uncommon, around 0.3%, but secondary amenorrhea is much more frequent, affecting roughly 3–4% of reproductive-aged women. And the notes add that it's particularly more common in athletes.
Okay, so primary is rare, but you'll likely see secondary amenorrhea quite often. Good context. Right, let's shift to the clinic. How does a patient actually present? What do you look for? What do you ask? Clinical features.
Well, obviously the main thing is the absence of periods. But the key takeaway from your notes is to actively look for other symptoms because, as we've seen, they often point towards the underlying cause.
Like
the notes mention. Hirsutism or acne suggesting androgen excess, think PCOS, or galactorrhea milk discharge from the breasts, which points towards possible hyperprolactinemia.
Got it. So probe for those associated symptoms, and the notes provide a really clear structure for taking the history, don't they?
Yeah.
What are the absolute must-ask questions listed?
Yes, the notes list these essentials. The precise duration the periods have been missing, any past or current contraception use, remember that can be the cause. Vasomotor symptoms like hot flashes suggests low estrogen, maybe POF. And alectorrhea, details on exercise habits, current stress levels, a full medication history. Some drugs impact prolactin, for example, and relevant past medical history. Ticking these off builds your initial picture.
It's like a practical checklist pulled right from the notes. What about the physical examination?
The notes outline the key steps. Calculate and note the BMI extremes of weight matter. Then, a general physical exam focusing on signs of potential underlying causes. The notes give examples like looking for signs of androgen excess, sutism, acne, balding, thyroid issues, goiter, eye signs, or Cushing's syndrome. In primary cases, assessing the stage of secondary sexual development is vital. And finally, a pelvic exam, vaginal and possibly bimanual, might be indicated, especially if you suspect a structural cause or a pelvic mass. The notes specifically say this is to rule out masses, pointing out not all are uterine.
Right, checking the anatomy makes sense. It's helpful how the notes often give the why behind a step. Okay, so history and exam provide clues. Then come the investigations to confirm things. How do the notes lay out that pathway?
They start with the absolute essential, non-negotiable first step in secondary amenorrhea, a pregnancy test. Always rule that out. After that, it's about hormonal assessment. The notes list the core blood tests: FSH, follicle-stimulating hormone; LH, luteinizing hormone; prolactin, thyroid function tests, TFTs; and androgen levels like testosterone.
And the interpretation of those results is crucial, isn't it? The notes cover that.
Hugely important, yes. The notes state, high FSH and LH often points to ovarian failure, like POF. If you see high FSH-LH and the patient has short stature in a primary case, the note suggests thinking about Turner syndrome. Conversely, low FSH and LH, especially with normal height, might suggest constitutional delay or a hypothalamic cause. High prolactin needs confirming and investigating further. High testosterone might indicate a tumor, but PCOS is a much more common cause of milder elevations.
Understanding those patterns is really high yield from these notes.
It really directs your next steps. TFTs are specifically listed as thyroid issues are a treatable cause. Pelvic ultrasound is mentioned as useful for suspected PCOS, looking at the ovaries, or for checking anatomy in primary amenorrhea, especially in younger girls.
Any other investigations mentioned for specific situations?
Yes, the notes list further tests, often needing referral. Karyotyping, chromosome analysis, for suspected Turners. MRI or CT scans if a pituitary tumor, for high prolactin, or an adrenal ovarian tumor for high androgens is suspected, and hysteroscopy, looking inside the uterus, if Asherman syndrome seems likely.
Okay, so investigations are targeted based on suspicion. Anything else noteworthy in that section?
Yes, actually, a very practical point about prolactin. Your notes specify that if the first test is high, it should be repeated, measured at least twice before launching into expensive scans like an MRI.
Oh, why is that?
Well, it's because prolactin levels can be temporarily raised by everyday things: stress, eating just before the test, even a recent breast exam. Repeating it helps ensure it's a persistent elevation before further investigation. A really useful clinical pearl from the notes.
That is a great practical tip. Avoids unnecessary workup. Okay, so we've defined amenorrhea, explored causes, assessed the patient, run the tests. Now, management. How do the notes say we should approach treatment?
The absolute core principle emphasized in your notes is treatment depends entirely on the underlying cause. You diagnose first, then you treat.
Makes total sense. You need to know what you're treating.
Precisely. General approaches listed include lifestyle changes, managing weight up or down, reducing stress. Hormonal therapy is common, like the combined contraceptive pill, OCP, or hormone replacement therapy, HRT. Surgery might be needed for structural problems like Asherman's or an imperforate hymen. And the notes add, importantly, that if fertility isn't a current goal and the cause doesn't pose other health risks, specific treatment might not always be needed just to restart periods.
Okay. Are there specific points for primary versus secondary management?
Yes. For primary, it's about finding and treating that specific underlying cause. HRT is specifically mentioned for conditions like Turner syndrome, Gonadaldysgenesis, and the notes highlight the reason: preventing osteoporosis due to the lack of estrogen. For secondary, the notes reiterate: first rule out pregnancy, lactation, menopause if over 40, then treat the identified cause. Hypothyroidism is mentioned again as a key treatable example.
Right. Treat the thyroid. Periods often return. Simple enough.
Exactly. Other points include fertility referral if needed, contraception advice if not, HRT for premature ovarian failure, POF, starting at before age 40 and continuing until around age 50, the typical age of menopause, reassurance and monitoring for constitutional delay, surgery for structural issues, reviewing medications if they're causing high prolactin, and specialized management for complex conditions like Turner's.
It covers a lot of ground based on the diagnosis.
It does. And significantly, the notes emphasize bone protection. Long-term lack of periods often means low estrogen, which is bad for bone density. So the notes stress assessing osteoporosis risks, ensuring adequate calcium and vitamin D, and considering HRT or OCPs if the amenorrhea continues for more than a year, depending on the cause and the patient's situation. This whole management section really hammers home that identifying the cause is everything because the treatment plan flows directly from that.
Absolutely. Diagnosis dictates the next steps. Okay, finally, let's look ahead. Prognosis and complications. What do the notes say about the long-term outlook?
Well, unsurprisingly, the prognosis really depends on the underlying cause and how quickly it's addressed.
And what are the main risks or complications if amenorrhea isn't managed, according to these notes?
The notes list 3 key ones. Infertility, which is often the main concern driving women to seek help. Osteoporosis, that loss of bone density we talked about, a major long-term health risk. And psychological distress, which shouldn't be underestimated.
Right. So it's clear from these notes that amenorrhea isn't just about period stopping. It can have really significant knock-on effects for fertility, bone health, and well-being, which underlines why a systematic approach, like the one laid out in these notes, is so important.
It really does highlight the need for thorough investigation and appropriate management.
So there we have it, a deep dive into your revision notes on amenorrhea. We've defined it, broken down the primary versus secondary distinction, explored that wide range of causes, walked through the clinical assessment history, and navigated the key investigations and how to interpret them, including that great tip about repeating prolactin, and discussed management, emphasizing how it hinges entirely on the underlying diagnosis.
Hopefully, going through your notes in this structured way provides a really solid, high-yield framework for understanding amenorrhea, whether it's for the MSRA or just general clinical knowledge.
Definitely. And thinking about all those diverse causes, from brain signals down to uterine structure, here's a final thought to mull over, based on these notes. Given this interconnectedness, what other, perhaps seemingly unrelated symptoms or clinical findings might make you pause and consider whether investigating potential menstrual cycle changes should be part of the picture, even if the patient doesn't initially report amenorrhea?
That's a great reflective question, encouraging that broader clinical thinking.
And listen, if you are prepping for the MSRA or similar exams and found this helpful for working through your notes, you might want to check out passthemsra.com and also freesra.com for more resources.
Good recommendations for those in the exam preparation phase.
Thanks so much for sharing your notes and joining us for this deep dive.
My pleasure. Until next time.